This CT scan in the coronal cut shows frontal sinusitis with the presence of two isolated cells in the left-sided frontal sinus. Now, it is very important to differentiate these cells from the anteriorly based cone cells from the posteriorly based frontal bular cells, which can normally be done only on a parasagittal cut. We shall soon see how these cells are different. Rest of the scan shows us patchy pansinusitis with a left-sided deviated nasal septum and a sharp spur, and also shows us the anterior ethmoidal vessels. There is some sphenoid sinusitis on the left side as well. The right side more or less looks clean. This happens to be a patient of pansinusitis with deviated septum on the left side. Now we can see that there is both an anteriorly based T3 cell is occupying less than 50% of the height of frontal sinus, as well as a frontal bular cell which pneumatizes along the posterior wall or the posterior table of the frontal sinus. And this, when scanned in a coronal cut, can look like or appear like an isolated frontal cell or a T4 cell, which it actually is not. We proceed with uncinectomy in a standard way using a backbiting forceps. This is a standard technique. We do not endorse using a sickle knife. Then by using a frontal sinus curette or a good quality strong ball probe, we can just back fracture the uncinate process, flush with the lateral nasal wall. And since the frontal sinus is in question in this patient, the uncinate process has to be removed right till the superior part of it. Now, as we can see, we are clearing off opening the antrum, doing an antrostomy using the same frontal sinus curette, fracturing the inferior wall and the posterior wall of the maxillary antrum. And now we take our same frontal sinus curette behind the bulla ethmoidalis and again use back fracturing technique to fracture the bulla ethmoidalis right from its origin towards the skull base. Now, once we have sort of fractured all these contents, we can simply use a 0 degree or a 40 degree microdebrider blade to remove all this redundant thin septations of bone and the excess mucosa to give us a clear view of the anatomy. It must be always borne in mind that the microdebrider blade must always be in vision when we are using it inside the entire sinus surgical work. Now, as we see, a generous antrostomy is being created by removing the excess wall on the superior wall of antrum, the posterior and the inferior wall of antrum, flush with the inferior turbinate. One must be careful not to make the posterior wall flush right to the posterior wall of maxilla, because that can traumatize the sphenopalatine vessels unnecessarily and produce brisk bleeding. It is not desirable nor required in a standard sinus surgery patient. Now, we always begin using an antrostomy, and once the anterior ethmoidectomy has been done, the uncinectomy has been done, a wide middle meatal antrostomy should be the first step in any sinus surgery, because it is a significant anatomical landmark. Just as we use intra-operative navigation to navigate our vision throughout this surgery as to what cells we are part of, what is the concerned anatomy around, the same way we must have a broad picture of the intra-operative navigation that we must have in our own mind when doing sinus surgery. All the walls of the maxillary antrostomy are careful landmarks. Now, as you can see, we are using the same microdebrider blade to go puncture the basal lamella, and it is done right at the level of the transitional antrostomy ridge, which is basically the junction between the vertical and the horizontal antrostomy ridge, the horizontal antrostomy ridge being the superior and the vertical horizontal ridge being the inferior, that is the posterior wall. Now, as we breach the basal lamella in the medial and the inferior aspect of it, just at the same level as the transitional antrostomy ridge, because that is the safest region, then we start removing the posterior ethmoidal cells gradually, superiorly and laterally. However, in a limited fashion. One of the most fundamental anatomical landmarks that we ought to see once we go through the basal lamella and remove it decisively, is normally the superior turbinate. And the superior turbinate can be seen on the CT as well as the intra-operative. Lateral to the superior turbinate, we have the drainage of the posterior ethmoidal sinuses. Medial to the superior turbinate, we have the sphenoid recess with a sphenoid sinus trace. Here you see this is the superior turbinate, which our microdivider blade is gradually dividing. We might leave the superior portion of it because that can carry the olfactory sensation, but the inferior half or inferior 2/3 of the superior turbinate can be safely removed either using a microdivider blade or using a sharp true cutting forceps as such to give us a clear vision into the sphenoid recess and the sphenoid sinus. Now you might clearly note as to how our dissection plane is right now straight in the trajectory of the transitional and the horizontal antrostomy ridge. The horizontal antrostomy ridge corresponding to the medial orbital floor always points towards the sphenoid ostium level. So whenever in a revision sinus surgery and loss of landmarks, one can always follow the horizontal antrostomy ridge and the medial orbital floor to guide us towards the approximate level of the sphenoid os and where to puncture it in case we are not able to negotiate it using our instruments. As we can see here, post removal of the superior turbinate, we have taken a shaver blade medial to it, following the septum, and right at the level of the horizontal antrostomy ridge or the medial orbital floor, we have already just entered our sphenoid sinus. As we enter the sphenoid sinus, sometimes the anterior wall is quite thin and can be widened by using a microdivider blade. Otherwise, we advocate using a Hedgek-Koffler punch, biting inferiorly and slightly inferiorly and laterally to enlarge the anterior face of sphenoid. The goal of surgery always, it has to be remembered, is to create an antrostomy not too big, but not sphenoid osteotomy, the sphenoid ostial opening not too big but not too small, because this has to be irrigated and some bit of it will obviously stenose post-surgery due to scar tissue. Once again, we clear some redundant mucosa onto the over the anterior face of sphenoid, and as we now know the lowest level of skull base in the sphenoid sinus, now we can safely and predictably proceed towards removing the rest of the posterior ethmoidal septations, which are a very important part of any sinus surgery. This is the posterior to anterior method of doing the sinus surgery. Now we can see our most important landmarks are the antrostomy. We can see some pus and some purulent secretions coming from the antrum, the posterior choana, how the sphenoid sinus is associated with the choana, and how the entire ethmoid septations can be dragged from posterior to anterior, from the sphenoid sinus towards the anterior ethmoidal sinus, and lastly towards the frontal recess or the frontal ostium as well. Now here we are using a navigator probe to once again reorient us towards the anatomy. That would be the anterior ethmoidal region, anterior ethmoidal skull base. As you can see, it is still behind the region of the agar nasi and the frontal recess. Now again, once we have used our landmarks, we use the frontal sinus curate to again back fracture. This is a wonderful instrument. We can always palpate what is the height of the structure that we are removing, and back fracturing it gives us a fair amount of security against not going through the ethmoidal skull base. Now this is pointing towards the agar nasi, and again this can be fractured from posterior to anterior. That is the lamina papyracea. Some bit of anterior ethmoidal bone may still be there, which can be removed, but most of it is lamina papyracea. That ought to be our lateral boundary of dissection. So opening the sphenoid obviously gives us a good boundary We know what is our posterior boundary, inferior boundary, lateral boundary being the lamina papyracea, and medial is the middle turbinate. Now we are using the hedgehog coffular punch to bite off some of the anterior wall of the agernasi. This could be done as a standalone procedure, or sometimes, as for Peter Wormald advocates, using an axillary flap over the anterior wall of agernasi. This has an advantage of giving us a head-on view and working for a longer length of time using a 0-degree endoscope. We're using a frontal sinus suction curette here to use suction and curette the thin bone of the agernasi and the frontal cells one by one using the same instrument. Now we again come back to our frontal sinus suction curette, trying to navigate our view inside the right-sided frontal recess and the right-sided frontal sinus. As we all understand, the frontal sinus, the trajectory of the instrument has to be superiorly and laterally, not medially. This again is the region of the cells of the frontal recess. Could be type 1, 2, 3 configuration, and which has to be broken using cell-by-cell dissection, either using a straight curette or a suction curette.
This person has
Now we use the microdebrider blade to again debride the erstwhile fractured posterior wall of the agernasi and remove some of the excess polypoidal redundant mucosa in the region of frontal recess to give us a better access towards the right-sided frontal recess cells and possibly the frontal ostium. Since this is a primary surgery with not much disease in the right side frontal sinus, we shall be quite alright with just opening the frontal recess adequately without doing any instrumentation in the frontal sinus proper, because that ought to induce scarring. However, in case of a revision surgery or gross fungal disease or access to the lateral frontal sinus, we may need to enlarge the frontal sinus ostium considerably. Here we're using the same hedgehog coffular punch to slightly increase our access towards the frontal recess, removing the anterior bone of the agernasi as high anteriorly as we can.
that's the background this article. Explain main hardly was Steve Cass. Jimmy.
Once again, we use our navigator probe to go inside straight towards the sphenoid sinus. The probe now points to the cellar floor, and followed by now the posterior ethmoidal roof. And as we come anteriorly, we shall go towards the anterior ethmoidal roof. There are some cell septations in the ethmoids which are still remaining and might need to be removed for complete clearance. Now we come to the left side, and the left side again, just as in the last time, we will initiate using an uncinectomy. So we can see here that the septal spur does cause some impediment to our dissection and overall access to the maxillary antrum. Post the enterostomy, now we are using this frontal sinus curette to back fracture the ethmoidal bulla, which shall later on be consumed with the microdebrider. So this is complete clearance of the uncinate process and exposure of the agar nasi cell on the left side, and also creating a reasonably wide enterostomy, again to be used as not just opening of the antrum but also as a surgical landmark to help us guide our way and navigate us throughout the posterior ethmoidal complex and the sphenoid sinus. This might become very valuable, particularly in the instances of revision surgery and scarring. We will not have the middle turbinate to guide us. This is the basal lamella being opened inferiorly. Once again, it can be seen how the initial opening is done at the level of the horizontal enterostomy ridge, or the superior wall of the maxillary antrum, also corresponding to the medial orbital floor. And that seems to be the right place because that guides us straight towards the sphenoid sinus, which is also the lowest point of anterior skull base. Once we have located the lower point, we can obviously anteriorly proceed. Now this is the superior turbinate. It happens to be a much thinner one as compared to the right side. And we can see how the sphenoid sinus drains medial to the superior turbinate through the sphenoethmoidal recess, and the posterior ethmoidal complex drains lateral to the superior turbinate. Just like in the last time, we shall be removing the superior turbinate, the inferior half, to make our access into the sphenoid sinus. This once again the navigator probe, again correlating the presence of superior turbinate intra-operatively to the pre-operative CT scan of the patient. Once our navigator probe correctly points our trajectory straight towards the sphenoid sinus, we take the fine straight cutting true cut and bite off the inferior portion, inferior half or so of the superior turbinate to widen our access towards the sphenoid sinus. And as we see, our dissection still is at the level of the horizontal enterostomy ridge, which is also the medial orbital floor, because that is the approximate level of the sphenoid os. This is the level of the transitional enterostomy ridge, the one that transitions between the vertical and the horizontal, and slightly above it, a fraction of millimeter, is the horizontal enterostomy ridge, which is approximately at the same level as the sphenoid os. As we see here, the sphenoid os is now open, and just like the right side, we need to be widened slightly using a Hajduk-Coffield punch inferiorly and laterally. And post that, once we identify the sphenoid conclusively and see the roof of sphenoid, which is the lowest point of skull base, we can again proceed to dissect anteriorly, progressively, and superiorly, following the posterior ethmoids. One thing to be borne in mind, very important, is the fact that merely opening the sphenoid and not opening the posterior ethmoids adequately is also a telltale recipe for surgical failures, because only when all the sinuses, all the ethmoid septations are taken down and they're opened widely is the patient able to really reap the benefits of irrigation of the sinuses using either saline or steroid-infused saline to prevent future recurrences. One of the most common failures of endoscopic sinus surgery, and often is understated, is the incomplete removal of the ethmoid septations and often leftover anterior or posterior ethmoid layer cells, which do not achieve any irrigation and are sort of sequestered and hence always lead to surgical failures eventually. Now, as we open more and more ethmoids, we keep going anteriorly, and as the skull base will slope superiorly from posterior to anterior, we can progressively remove more bone using a punch while palpating the level of the skull base. Once again here, the same hajek-Koffler punch is now used to increase our access towards the left-sided frontal recess by removing the anterior and the posterior walls of the Ager nasi on the left side, so as to get a vision of the frontal recess on this side. As we can see, there are still some septations left, and which will again need to be taken down to achieve a uniform and a clear access of the entire ethmoidal skull base. We can see here how we can assess the depth of the ethmoidal septations using a curved elevator or a curved frontal sinus curette, and once done so, we can again fracture and open these septations so as to achieve gross clearance of the ethmoid complex and make it more amenable to clear, consistent nasal irrigation, especially using steroids-infused saline. As we do so, we keep going inside the frontal recess, trying to back fracture, and the technique of back fracturing actually is quite safe because the chances for any skull base penetration or trauma are substantially less unless we do very jerky movements. And as we see, gradually the recess is being opened using at present only a blunt frontal sinus curette. Now, due to the deviated septum, which shall be dealt with later using the septoplasty, we can resort to an angled microdebrider blade, normally a 40-degree one, to give us a good trajectory of surgery to widen the access to the maxillary antrum, enlarge the antrostomy, and also to clear the ethmoid complex and the frontal sinus. It is particularly useful in instances of some deviated nasal septum if that is not to be dealt during the same surgery for some reason, but normally it is recommended that we do. In this patient as well, the deviated septum will be dealt after completion of sinus surgery, not because the surgery cannot be completed, that it can be, but overall the obstruction would still remain, and the irrigation and the post-operative control in the office would be suboptimal in the absence of addressal of the septum. So now we can use this 40-degree angled shaver blade in a guarded fashion to clear off the redundant mucosa and the excess cells in the ethmoidal complex, in the posterior ethmoids. Now one can start appreciating the whole 3D anatomy by orientation of the maxillary antrum and its walls with the sphenoid and the ethmoidal complex. Now our suction is an olive-tip suction, the frontal sinus suction. We are trying to navigate our way inside the frontal recess. And we see here there is a considerable amount of polypoidal mucosa here, which we are gradually and gently debriding, trying to avoid circumferential trauma because that often leads to sure shot scarring and possibly restenosis. Since it's a primary case, so it's polypoidal but not with any history of asthma or aspirin sensitivity or excessive polyposis, there seems to be a case for justifying a conservative sort of a surgery to begin with as much clearance, but not causing excessive mucosal trauma or scarring, and not being too surgically aggressive. However, trying to achieve gross total removal of all ethmoidal septations and sinuses is fundamental to the success of almost all sinus surgeries, whether done for polypoidal or non-polypoidal disorders. The frontal sinus, the frontal recess has been opened, and as we see here, there's some edematous mucosa, but we would prefer not to scar it too much, or to use the debrider inside it, inside the sinus without seam. The anterior ethmoidal sen complex behind the frontal sinus has been opened, and once it is freely irrigated, it seems to be a reasonable place to consider completing the surgery. Like I said, this would be followed with a formal septoplasty to give us better access in the post-operative times, and to be able to improve the patient's breathing, as well as help in the overall process of nasal irrigation, which would be hampered if the septum is not corrected. So as you can see, we could make do with the surgery with the septum, but obviously in the post-operative period we cannot control the open sinuses nor clean them in the office unless we manage this septum cleanly.